Hello, my name is Lisa Majeski West, and I am the president of Gold Star Medical Business Services. I'd like to talk to you today about a very important topic that is going to affect us in the chiropractic profession in the way we are reimbursed for the next few years and many years to come. And this topic is based on a new law that has been passed called MACRA. I know many of you have probably heard about this and heard that this is coming down the pike, but I also know from speaking to many doctors that there's a lot of misunderstanding about it, and there's a lot of confusion about what this is and how this is really going to affect our practices in the future. So I wanted to present this to you to give you an opportunity to learn about MACRA, learn about what it's going to do to you as far as your practice goes and the way you practice your craft, and hopefully give you some tips and some tools to allow you to transition to this new payment model as effortlessly and as painlessly as possible. I always know there's going to be effort involved, but hopefully we'll be able to cut through a lot of the noise and confusion about this program and get down to the heart of it and what you actually need to do. So before we get started, what I'd like to do is just give you some information about myself and who is speaking to you today. Again, my name is Lisa Majeski, and I've been in the chiropractic field since 1982. I started out as a CA in various positions: front desk, back office, insurance billing and collections departments, and worked as a CA on and off for many years, through the years of 1982 through 1994. During that time, I also worked at a few medical clinics and even a dental clinic as a dental assistant. But I did stay in the medical field and primarily concentrated my efforts working in the chiropractic field. In 1994, I had the privilege of becoming the clinic director for a multi-doctor, multidisciplinary clinic in West Texas, and I was their clinic director for 5 years. During that time, I helped the doctor that I worked for set up satellite clinics, hire and fire, unfortunately, associate doctors and staff, and run the overall clinic operations. I had my finger in all of the pots, including the front desk, the back office, and in billing whenever was needed. So I was kind of the chief cook and bottle washer there for a long time. In 1999, I was hired on with Katz Management to be a senior consultant with them, and I was there for 10 years when Dr. Katz sold the business to his partner, and it became Integrity Management. I stayed with them for several more years, and in 2006, I started a company of my own called Gold Star Medical Business Services. And Gold Star Medical was a company that I started essentially to provide a part-time job for my husband. I taught him how to do medical billing, chiropractic billing actually, and work from home. He was disabled. And so this was basically a way to start a little cottage business for him, to give him something to do since he was not able to work outside the home. And so we started out primarily just doing chiropractic billing, but since that time we have branched out into consulting, compliance auditing, clinic efficiency auditing services. And so also during this time, after my husband passed away in 2009, I took over Gold Star Medical and have been working it full-time. We currently service 61 offices throughout the United States. The majority of them are chiropractic clinics, but we also do billing for medical clinics of various medical specialties. And since that time, I've obtained certain certifications. I am a certified medical compliance specialist with an additional specialization in chiropractic compliance. I'm a certified medical coder and a certified medical office manager. I'm also on the faculty of Practice Management Institute and currently spend a lot of time with them teaching conferences all over the country, primarily to medical doctors, and I've go around and teach at hospitals and large clinics on medical coding, compliance, and practice management. I'm also on the faculty of the Angelo State University Small Business Development Center and teach business classes for them. And in my spare time, I'm a sports mom. I have 3 active teenagers and 2 adult children. I'm a grandmother. I'm a certified yoga instructor, and I'm totally addicted to pickleball. So if you want to know what pickleball is, you'll have to call me. Otherwise, I'd spend the whole time talking about that. So with all of that said, I just wanted you to know who was presenting this information to you. And let's get down to the meat and potatoes of this presentation. What we're going to be talking about today is the Medicare Access and CHIP Reauthorization Act of 2015, all fondly known by the medical community as MACRA, and the component of MACRA called the Quality Payment Program. MACRA actually is a much larger bill, but within the bill is the Quality Payment Program, and this is the part that we're going to discuss today. And this is the part of the MACRA program or the MACRA law that is redefining how physicians are getting paid. I do want to let you know that this presentation was current at the time it was published, which is right now, it's December of 2016, or uploaded onto the web. Much of the information that you're going to see today came directly from Medicare and from CMS. And so, you know, I like to deal with the knowns and not the what we think about things, but what we know. And so I do use a lot of information from Medicare directly to help us understand these programs. This is prepared to you as a service to the public, and it's not intended to grant rights or impose obligations. This presentation may contain references or links to statutes, regulations, or other policy materials, and the information provided is only intended to be a general summary, and it's not intended to take the place of either the written law or regulations. I do encourage you readers, or if you're listening to me, to review the specific statutes, regulations, and other interpretive materials for full and accurate statement of their contents. So with that out of the way, let's go ahead and get started. Before I can really explain MACRA to you, what I need to do is explain to you how we got here and how we got to MACRA. And really, MACRA began a long time ago. The seeds for MACRA began a long time ago with the passage of the Sustainable Growth Rate Bill. This was established in 1997 to control the cost of Medicare payments to physicians. And what happened was Congress went to Medicare and basically said, we're going broke. If we keep paying out the kind of payments to physicians that we are now, we're going to go broke probably within the next 10 years. And the reason why we're going broke is because there's a tremendous amount of waste, fraud, and abuse taking place in the Medicare program. Physicians are overbilling, overcoding. There are physicians that are simply committing waste within the Medicare program, but there are also physicians and groups of physicians and durable medical equipment suppliers and other entities that bill Medicare that are actually committing fraud on the Medicare program and the Medicaid program. And so we're going to go broke. And so Congress reacted, and they reacted very swiftly with the Sustainable Growth Rate Bill. When the SGR hit the fan, so to speak, and the medical community got wind of it, there was such an outcry from the medical community that they basically said, as a whole, wrote to their congressman and said that if the SGR moved forward and we were going to be cut, and at the time the cut was estimated to be 13%, if we were going to get a 13% cut in Medicare reimbursements, we will all opt out of Medicare, and you will just not have enough doctors to service your Medicare patients. So with that, Congress had to react again, and they placed a temporary fix to avert cuts each year. And so each year the SGR came up for review, and each year a fix was put in to waylay the SGR, so basically put a freeze or a moratorium on it. For example, if the doc fix hadn't been in place in 2015 to avert the cuts, it would have meant a 21% cut in Medicare payments. So basically what the SGR was saying was that if the overall physician costs were greater than the target Medicare expenditures, the next year would result in the cuts. And the cuts would be across the board. So what doctors said was, look, you are essentially penalizing good doctors for the bad behavior of a small majority of doctors and physicians and entities, Medicare entities, eligible entities that are bilking the Medicare system or committing, wasteful spending. And we don't think that's fair. We think that there needs to be equity where physicians who perform well, who don't overbill, who document their services, are rewarded for that. And if you're going to cut anybody, cut the lower performing entities, the ones that don't document what they do, that simply bill out massive volumes of services, and and look at them and look at what they're doing and audit their services and see where this waste is taking place, but don't just cut everybody. So what happened during the period of time between 1997 and the passage of MACRA was several different programs. One was the establishment of the OIG oversight, and that the OIG stands for the Office of the Inspector General. And the OIG basically developed every year and continues to develop a work plan. And you can go to the oig.hhs.gov website and look up the work plan every year. And if you look at the physician services, you will see that each year there are a number of entities and procedures and policies and payment systems that are for review by the OIG. And when we say for review, it means an increase in audits. And the chiropractic profession has been on the OIG work plan, and chiropractic billing and billing for unnecessary services has been on the OIG work plan for the last 6 years in a row. And so the OIG took oversight of the Medicare program. PQRS and meaningful use was introduced to help reduce waste in the Medicare program. Specifically, when we're talking about waste, we're talking about waste of duplicate services being offered to patients, duplicate prescriptions being sent to patients by various doctors. You have to realize that a lot of patients will have 5 or 6 different doctors, and they may have 3 doctors giving them the same the same prescription. And so the EMR program and the patient portals were designed to be developed to help avoid that and place all patient records in one place so that all doctors could review the same patient records from other physicians to curb waste. PQRS was developed to give measure to quality performance within doctors' offices. So if doctors were performing quality services, they would be able to attest to that and receive reimbursements and incentives for those attestations. So what happened was when Obamacare, or the PPACA, the Patient Protection and Affordable Care Act, was signed into law in 2010, these programs, PQRS and meaningful use, ceased to become voluntary programs and became mandated. So they were mandatory programs now, and any incentives that were being given were done away with, and they began to give negative payment adjustments if you did not participate. And so over a period of time, the programs that were incorporated into the PPACA were then developed into the MACRA law. In April of 2015, the MACRA, the Sustainable Growth Rate formula was repealed, the law was repealed, and MACRA was put in its place. And under MACRA, there is the Quality Payment Program, and the Quality Payment Program allows for 2 different tracks. One is the Merit-Based Incentive Payment System, which is called MIPS, or the APM, which is the Advanced Alternative Payment Models. Under the APMs, You know, those are mainly for large accountable care organizations or large physicians groups that could participate in the APM models. So as chiropractors, the majority of you, probably 98% of you, will be participating in the new quality payment program, which is a law, so it's mandated. This is not something that you have an option to do. You must do this in order to not receive significant pay cuts in Medicare. You will be participating in the merit-based incentive payment system. And so with that said, we want to make sure, and I particularly want to make sure, that doctors of chiropractic don't get left in the dust and don't find themselves seeing significant pay cuts in their Medicare reimbursements. Also, what I am seeing and what we're seeing industry-wide is that commercial carriers are following suit, and I'll actually show you some examples at the end of this presentation that will help you see and understand how far-reaching this program is. So let's get talking about the quality payment program. Now, prior to MACRA, which again was signed into law in April of 2015 with implementation starting January 1st of 2017. We had multiple quality and value reporting programs for Medicare clinicians. One was the PQRS program. The other was the value-based payment modifier, which really was not a reporting, it wasn't anything you needed to attest to. This was mined from your claims data. And then the Medicare EHR incentive program, or what we know of as meaningful use. Now what's going to happen is MIPS takes these three independent programs and streamlines them into work as one to help ease clinician burden of the reporting, but also adds a fourth component to promote ongoing improvement and innovation to clinical activities. I'm kind of excited about this part of the MIPS program, which is the clinical practice improvement activities portion of your score, because these are actually programs that could help you build your practice and become more profitable. And we'll talk about that a little bit more here as we progress into the presentation. MIPS provides clinicians the flexibility to choose the activities and measures that are most meaningful to their practice to demonstrate performance. So the question is who participates in MIPS, and the affected clinicians who will be participating in MIPS are the MIPS eligible clinicians. In years 1 and 2 of this program, which is 2017 and 2018, this will consist of physicians, PAs, nurse practitioners, clinical nurse specialists, certified registered nurse anesthetists, and under the physician category, this will include a doctor of chiropractic legally authorized to practice by a state in which he or she performs this function. In years 3 and moving forward, the Secretary of the Department of Health and Human Services may broaden eligible clinician groups to include others such as physical or occupational therapists, speech-language pathologists, audiologists, nurse midwives, CSWs, clinical psychologists, dietitians, and nutritional professionals. Who will not participate in MIPS? And there are actually going to be a group of chiropractors within our profession who will not be subject to MIPS. So this is important for you to know. Number one is any clinician who is in their first year of Medicare Part B participation, you will not be subject to MIPS. Okay, so if you're brand new in practice, or you have been in practice but never enrolled in Medicare, and this is the first year that you have enrolled in Medicare, then you are not subject to reporting in 2017. The other group, which is the much larger group that will probably encompass a fair portion of the chiropractic profession, will be doctors who are below the low patient volume threshold. And the Medicare low volume threshold has been set to $30,000 in billed services, and doctors who provide care for 100 or fewer Medicare patients in 1 year. So basically, if you run your stats at the end of the year of 2016, which is when we're talking about this, this presentation is December of 2016. So at the end of this year, you'll want to run your stats, and you'll want to see if you had fewer than 100 Medicare patients and if you billed less than $30,000. Now, if you billed less than $30,000 but had more than 100 Medicare patients, you are not exempt. If you had more than 30,000 but fewer than 100 Medicare patients, you're not exempt. It has to be both. So you have to meet the criteria of billing less than 30,000 in services and have provided care for fewer than 100 Medicare patients in 1 year. And it's not Medicare patient visits, okay? Right now, DCs are not participating in APMs, or if they are, it's not very many. It's just, it may be a handful of DCs that have been invited to participate in an ACO that has been designated as an advanced payment model. So really what we're going to be talking about today is MIPS, and anyone who is in an APM does not participate in MIPS. MIPS also does not apply to hospitals or facilities. So let's talk about what these payment adjustments can be and will be starting in 2019. Now, you know, you may ask yourself, well, it's just the end of 2016. Why are we even talking about this? Because everything you do or don't do in 2017 is going to affect you when these payment adjustments take place in 2019. So if you look at the blue line that is going across your screen right now, and you'll see the purple lines that are crisscrossing it, each one represents a year of eligibility. In 2019, the blue line represents the Medicare fee schedule, okay? And some doctors will follow the blue line. They will just get paid based on the Medicare fee schedule, based on what they report or don't report. They may, if you report extensively and you do all of the reporting requirements that you're supposed to, you'll be receiving as much as a 4% positive payment adjustment. But if you don't do any reporting and you are eligible to report, you're not exempt, then you would receive a 4% negative payment adjustment. Each year, the payment adjustments will be significantly higher or lower. So in 2020, those adjustments will be 5%. In 2021, they'll be 7%. In 2022 and onward, they'll be 9%. And this is how the MIPS payment adjustments are going to work. The Medicare fee schedule will freeze in 2020. There will no longer be any increases to the Medicare fee schedule. And the Medicare fee schedule is scheduled to stay the same for at least the next 5 years. So you may say to yourself, well, you know, maybe I'll just do some minor adjustment, a minor reporting, and not worry about getting the negative payment adjustment. I'll just get paid on the fee schedule. I don't care about the increases. Well, think about this. If the fee schedule doesn't change and for 5 years, think about your costs of practice in 2020 and the cost of doing practice in 2025. And think about the number of patients that you had that may now all of a sudden be eligible for Medicare, where you were receiving really good reimbursements from commercial carriers, and now they're on Medicare. And you all of a sudden, you're seeing the value of your dollar decrease every year, even though the payment adjustment is not changing. So think about that. So again, the fee schedule updates, you'll see from in 2015 there was a 0.5% update. In 2016 through 2019 it will continue to increase 0.5%, but then from 2020 through 2025 there will be no increase in the physician fee schedule. And beginning with 2026, if you're in an APM, you're looking at about a 0.75% increase, and for other physician fee schedule services, non-APMs, that would be 0.25%. So it would be very, very negligible. Now, The eligible clinicians, which doctors of chiropractic we've already established are eligible clinicians, you will be able to participate in MIPS as an individual or as a group. A group is defined by a tax TIN, would be assessed as a group practice across all the MIPS performance categories. Okay. Now, there has been some question and there's been some talk about how do we get exempt doctors, in other words, doctors who meet that low volume threshold and probably never will be able to receive increases under MIPS. How do we give them the opportunity to make more money with their Medicare patients? And one of the things Medicare is working on is they are working on developing virtual groups that doctors will be able to join, virtual ACOs that doctors will be able to join in order to create as a group the increase in the low volume threshold to where you would become an eligible entity under the group. Right now there are not any virtual groups that are going to be implemented in year 1 of MIPS 2017. But keep your eyes and ears open for that. It would be a good idea to get on the listserv or on the email updates of the QPP, or the Quality Payment Program. And at the end of the presentation today, I'll have a link for you to sign up for updates to this very, very important program. So when does the Quality Payment Program start? The first payment adjustments will go into effect on January 1 of 2019, but the program starts January 1st of 2017. If you're ready, you can begin January 1st of 2017 and start collecting your performance data. If not, you can choose to start anytime between January 1st and October 2nd of 2017, and then your data will need to be sent in by March 31st of 2018 in order to be eligible for the MIPS adjustment on the positive side. In 2017, you're going to be allowed to pick your pace in MIPS, which is a very nice feature that they've put into play. This may change in future years, but at least for 2017, you will have the option to not participate at all. And in that case, if you're eligible, at a MIPS eligible provider, you would receive a negative payment adjustment in 2019. You can do a test submission or 1 day worth of submission in 2017 and be placed immediately into a neutral payment adjustment, which means you won't get a raise, but you will not receive the negative payment adjustment. If you submit for a partial year, you're looking at about a 90-day, which is 90 days. You might receive a small payment increase, and if you submit for the full year, you would be subject to the 4%. I am thinking that the majority of the chiropractors will probably fall within the middle 2 categories, which is the 1 day to 90-day range. But you know, the thing is, if you're already doing your PQRS measures and if you're already on EMR, there's no reason why you can't submit for a full year and receive the full benefit of the positive payment adjustment. So just in summary of the last slide, if you're not participating in 2017, then you would receive a negative 4% payment adjustment. If you submit a minimum amount of data, 2017 data, which is called a test, 1 day, again, all you have to do is submit for 1 day, you would avoid the downward payment adjustment. A partial would be if you submit 90 days of data to Medicare, you could earn a neutral or small positive payment adjustment. And if you submit a full year of data to Medicare, you would earn a moderate positive payment adjustment, or 4%. Okay, so we know that the payment model is going to change, but how? And basically what's going to happen is MIPS is going to take the programs that are already in place, add one other component to it, and create a composite performance score. So the quality portion of the MIPS score is what we know of now as PQRS. The resource use is what we now know as the value-based modifier. The advancing care information category is what we now know as meaningful use or EHR technology. And the clinical practice improvement activities is the new category. So here's how it's going to be weighted. The way this is, oh, I just went too far. Let me come back up here. Okay, so the way this is going to be weighted is the quality category is going to hold the most weight and will represent 60% of your MIPS composite score. And again, this used to equal PQRS. The resource use and the advancing care information has been combined and will represent 25% of your composite score, and then clinical practice improvement activities will represent 15% of your score. So under the MIPS quality performance category, the summary of this is going to be that you would select 6 measures, of which one is a cross-cutting measure and one is an outcome measure, or another high priority measure if outcome is available. Doctors would be able to select from individual measures or a specialty measure set. Now, here's the good news. On the quality performance category, what we anticipate is that your measures are going to be the same as they were in PQRS, which is only 2 measures. Since you would qualify under the physical medicine specialty measure set, and since the 98940 and 98941 codes and 98942 codes right now, which are your chiropractic spinal manipulation codes, are the only services that are covered by Medicare, these are the only measures that pertain to those codes. And so at this point, it does not appear as if you will have to report any more than the 2 measures that you're already reporting under PQRS, okay, for that 60% weight. So you know, this is definitely something that you would want to implement right away. The other thing is that under these 2 particular measures can be reported by claims. So you would just need to report these measures with your G codes according to the claims. And I actually have some examples of what these 2 measures are in this presentation. And if you want a complete white paper on each of the measures and how to understand what your documentation requirements are for those measures, I can email you those white papers on request. You can just send me an email and I'll have my information posted at the end of this presentation. Under the Advancing Care Information category, which we now know as Meaningful Use or EHR Incentive Program, this would account for 25% of your MIPS score in the first year. And in order to be eligible for scoring under this category, you must use certified EHR technology. So if you're still on travel cards or on paper charts, you would have to move to EHR technology. Okay, and you would have to report that you have the technology that meets the criteria for certified EHR, and you would have to attest that you are using that technology as well. Okay, the overall advancing information score would be made up of a base score and a performance score for a maximum score of 100 points. Now, how this works is the base score is essentially, what do we have? Okay, yes, we have EHR technology. Yes, it does protect patient health information. It's HIPAA compliant. It does have the availability of a patient portal, yes or no. Can we do coordination of care through patient engagement? Do we have e-prescribing? And of course, that does not apply to chiropractors. Do we have the ability to take the information and place it into a health information exchange? And do we have public health and clinical data registry reporting? Now, for chiropractors, you will probably be scored under the PHI, under the patient electronic access, and under the health information exchange components. And there are enough points within the base score for you to receive your total of 50 points, okay? And so you certainly would be able to max out on your base score even though you don't do e-prescribing. The performance score is okay, we have the EHR technology, but are we using it? Are we sending patients to their portals for updates to their treatment plans, for updates to appointments, and so on and so forth? Do we do coordination of care through patient engagement? And are we submitting the patient records into a health information exchange for their primary care physicians to have records of, and so on and so forth? And what you'll do is you'll select the measures that best fit your practice from the different following objectives. Now, you know, one of the biggest questions that I get is, well, which measures do I choose? How do I implement this? And that is kind of a discussion for another day. It is going to be highly individualized, and so any of you who are listening to this who would like more information is certainly able to give me a call or send me an email, and we can have a discussion about your individual situation. Under the clinical practice improvement activities category, this will account for 15% of your MIPS score in the first year, and for this category, MIPS would reward clinical practice activities such as activities focused on care coordination, beneficiary engagement, and patient safety. And there is a list of more than 90 different options. And guess what, docs? One of the options is a back care class. And so if you do spinal care class in your facility already, you would be awarded the points under the clinical practice improvement activities. You would simply have to attest to it. And so so that's good news. And you know, things like back care classes and weight management classes and weight loss clinics, all of these are considered clinical practice improvement activities. Having a patient portal, having after-hours appointments, having appointments for emergency care, same-day emergency care, which almost every chiropractor does, all qualify under the clinical practice improvement activities category. And so really and truly, most chiropractic offices are already there. It's just going to be a matter of finding the measure and attesting to it in your registry. So again, these are just some quick examples of clinical practice improvement activity categories and what they represent. Some of them, you know, for chiropractors are not going to be really applicable, like population management programs and that type of thing. But, you know, certainly beneficiary engagement, expanded practice access, and care coordination, you certainly can have those programs implemented into your practices in order to get credit for the clinical practice improvement activities. So the question here now is how do we report all of this? We have all of these measures that we have to report, all of these qualitative activities that we have to attest to, and how do we do it? So the rule for MIPS and MACRA proposes to allow third parties, including registry, qualified clinical data registries, health information technology developers, and certified survey vendors to act as intermediaries on behalf of your clinicians and submit data as applicable. And certain quality measures will have the option to report via claims. Not many, but the chiropractic measures on the quality component of the composite score, you will be able to report via claims. But the other two components, you would be looking at having to report through some type of a registry, okay? For many of you, if you have certified EMR, you can check with your EMR vendor to see if they have if they are going to be doing that reporting for you. Some of the EMR vendors already have that, and you can check with your vendor to see if they are going to be helping you with the reporting of your requirements under MIPS. How, you know, the question has been asked of me, should you report as an individual or as a group? The majority of chiropractors are going to be reporting individually, and the reason for this is simply because it is It is easier, and there are fewer requirements. If you report as a group, you have to report 15 measures. Well, we don't have 15 measures. And so it may even be that Medicare will deem reporting as a group to not be valid. I don't see that yet, but they haven't worked out all of the kinks. So my recommendation is going to be to consider reporting as an individual. What will happen is your MIPS data will be sent in as an individual. Your payment adjustment will be based on your performance. So another benefit to reporting as an individual is if you have, let's say you're in a practice where you have, 3 or 4 doctors in the practice, and one of the doctors is let's just say it nicely, is kind of a holdout. They've been in practice 30 years. They don't want to go to EMR. They just don't want to do any of this. They're retiring in a couple of years. Well, if you report as a group, their non-compliance would affect your group score. And so, the holdout would receive the negative payment adjustment, and then the doctors who are doing their reporting would be able to take advantage of the reporting. So, these are some of the things that you just want to make sure you understand, whether you should report as an individual or as a group. Okay, so most participants, when you are reporting the quality measures, you will be reporting up to 6 quality measures, and including an outcome measure for a minimum of 90 days. If you're a group and you're using the web interface, you would report 15 quality measures for a full year. And again, that gives you a weight of 60% of your composite score. Chiropractors will be 2 measures. And so this should be a fairly easy component of the QPP to get going on. All right. Now, the clinical practice improvement activities, you'll need to attest that you completed up to 4 improvement activities for a minimum of 90 days. Groups with fewer than 15 participants, and this again if you're reporting as a group, or if you're in a rural health or professional shortage area, you would attest that you completed up to 2 activities for a minimum of 90 days. And this piece of the pie just kind of gives you an illustration of how you're going to be scored. You're going to be scored based on quality, and again, quality is what? PQRS. Under the green section. Under the blue piece of the pie, that's your advancing care information, and that is your meaningful use. And then you'll have clinical practice improvement activities, which take up 15% of the composite score. This is just an example of one of the quality scores that we actually use now in PQRS, which is now being incorporated into the quality measure under the QPP, which is the pain assessment and follow-up. When you look these measures up on the QPP website, it'll give you this type of information. It'll give you the ID, the quality ID number, which is 131, and that's the same PQRS measure that we use now, which is PQRS measure 131. It tells us that it's a high priority measure, which is good because we have to have at least one high priority measure. We can submit through claims or registry, and it is part of the physical medicine specialty measure set. And then they will also provide you with a tremendous amount of detail on what this applies to. So again, I have the complete white paper on measure 131 for you. If you need it, you can contact me and I'll be happy to provide it to you, or you can go to the Medicare website, type in the search engine QPP or Quality Payment Program. When you get there, click on the quality measures and look up measure 131, and you can print this off yourself directly from the Medicare website. This is measure 182, which is the other measure that we are required to report under PQRS now, which will be the other measure that will be under our quality payment program, which is the functional outcome assessment. And this is where you do functional outcomes on your patients at your re-exams and so on and so forth. And for Medicare, Part B patients, this would be every 30 days. Here are some examples of advancing care measures under the QPP. So this would be providing patient access, meaning that you have a patient portal that your patients have access to. And it gives you information that this is required for the base score. Remember, the advancing care information section is going to be broken down 50-50. 50% of the score is going to be based on what you have, and 50% on what you do with what you have, meaning, yes, I have the patient portal, but do I encourage my patients to use the patient portal? Population and population health research is another example of this would be an example of a clinical practice improvement activity or use of telehealth services that expand practice access. These are just some examples that I'm showing you of the different options, and again, there are over 90 of them, of clinical practice improvement activities that you can choose from, and you must do 4 within a 90-day period. Okay, so in summary, let's talk about how this is all going to work. Number one is, you, as a DC, as a doctor of chiropractic, you are considered an eligible clinician, and you are eligible if you do not meet, or if you do meet the threshold. And if you don't meet the low volume threshold, then you are not required to do any reporting. The MIPS and Quality Payment Program reporting will only be required on Medicare Part B patients in 2017. So remember, when you're looking at your thresholds to see if you fall within the low volume threshold exemption, only count Medicare Part B patients. You would not count Medicare Advantage patients. They will be introducing Medicare Advantage into the mix in future years, but not in 2017, and maybe not even in 2018. In 2017, the MIPS and QPP reporting will affect Medicare Part B payments and payment adjustments in 2019, and that will be anywhere from up or down 4%. In 2017, which is next year, and 2018, what we're talking about is we're still working under the reimbursements from our participation in PQRS and EHR meaningful use and the value-based modifier. And so if you participated in PQRS and EHR meaningful use in 2015, then your payment adjustment will be up or down 2%. If you did not participate, it will be down 2% in 2017, and then if you did not participate this year in 2016, then your payment adjustments are going to be affected in 2018. So really and truly, you know, if you've never participated in PQRS and meaningful use, you have to start doing it. You might as well do it, and it's actually easier than it used to be. So you know, the reporting requirements are not as difficult as they were, and it just makes sense to stop the bleeding. You know, I mean, you just need to get on board with this in 2017. Get going. You have a full year, pretty much until October 1st, to avoid a negative payment adjustment. And there really is no reason not to. It's not hard to get onto some type of an EMR program. If you don't already have one, there are free programs out there. There are super low-cost programs out there that are certified for EHR meaningful use that you can get for your clinic. And remember, you only have to do if you're on paper charts. Remember that in 2017, you only have to transition your Medicare Part B patients to EMR. So this would be a good way for you to start getting used to using EMR by doing it with just your Medicare Part B patients. If you don't want to jump all in, you can start slowly. If you meet the low volume threshold exemption, or if you're in your first year of Medicare eligibility, you'll not be required to do any reporting. So good news for you. But again, you'll also not be eligible to receive any positive payment adjustments until you exceed that low volume threshold. Under the low threshold, you won't be penalized. And that's good news. But you know, we want to try to get you to a point where you are exceeding that low volume threshold so you can take advantage of the increases that will be taking place in Medicare Part B reimbursements. So how is MACRA affecting commercial claims and carriers? Again, as I said earlier in the presentation, commercial carriers are already introducing programs and policies that will tie reimbursements to quality care. And we know, many of us have already seen this, that commercial carriers are already tiering physicians and in particular doctors of chiropractic. Optum Health and United Healthcare is a prime example of this. If you are a doctor of chiropractic and you participate with United Healthcare, you know that unless you are a top tier physician, a tier 1 physician with Optum Health, then you are having to do pre-authorizations for services and predeterminations for services, and or what they call prior notification. But if you become a tier 1 physician, then you no longer have to do that. So, you know, other examples of commercial carriers that are rewarding quality of care. A great one here is in Texas. They have a program that they're initiating called Bridges to Excellence, Blue Cross Blue Shield of Texas. And while this doesn't really affect chiropractors at this point, this is just one example of what insurance carriers are doing to reward quality care. They are actually inviting physicians who treat patients with diabetes, cardiac, asthma, or inflammatory bowel disease conditions to become BTE recognized, and they may be adding obesity. So if you have a weight loss program, you know, you may actually be able to become eligible for these type of incentive programs. And have an opportunity to earn annual incentives for providing excellent care based on BTE guidelines. So, like for instance, Blue Cross Blue Shield of Texas is going to pay a BTE recognized or credentialed physician $100 or $150 per patient per year who are involved in this program. So essentially, if you say, well, you know, I'm treating 300 patients under my diabetes care program, and you're a BTE recognized physician, not only are you going to have that standard when patients go to search for you under the Blue Cross Blue Shield of Texas provider portal, but you'll get a bonus of, I'm not sure if it's going to be the $100 or the $150, but let's just say it's $100. If you have 300 diabetic patients within your practice, that's a $30,000 bonus. That's a pretty nice chunk of change for implementing a program to improve diabetes care for your patients. Cigna already has quality measure initiatives available online for you to look at, and it gives you the different links here, cignaforhcp.com, and then you go to resources, medical resources, commitment to quality. It gives you some of the quality programs that Cigna is initiating. One of them is called Care Allies, okay, and Care Allies is a program that helps you work with your community to provide value-based solutions for multi-payer environments. So, you know, again, insurance carriers pay attention to what happens with Medicare, and because this is a federal law, most insurance carriers who do provide Medicare plans in the role of Medicare Advantage are already preparing themselves for having to comply with the MACRA program. Humana, very interestingly enough, now is requiring, if you are a Humana provider, they are now requiring that you attest to having a compliance program, and that you meet the compliance program requirements. And Humana has a list of compliance program requirements on their website. So when you go to be re-credentialed or you go to be credentialed with Humana, you will have to attest to the fact that you have a compliance program in place. And many, many other carriers are doing this. Many Medicaid programs are requiring that you attest to having a compliance program. And we are looking within the next couple of years that when you do your revalidation for your Medicare enrollment, that you will have to attest within your revalidation that you have a compliance program within your practice. And so if you need more information about compliance programs and what a compliance program entails, what you need to have to set up a compliance program, by all means, feel free to contact me, and I will be more than happy to provide information for you on that. Another thing that Humana is doing in response to part of the PPACA law, which is the Patient Protection and Affordable Care Act, is that they are requiring doctors to have availability of translation services. This is actually a Medicare mandate. Many people don't realize this, but we have been mandated, if you're a Medicare provider, to provide translation services for your patients at your cost. And we don't know if this provision of the PPACA will be repealed if and when PPACA is repealed, or if it remains as part of the component of whatever new health care law replaces it. But you have to keep these things in mind, and you need to know what your compliance requirements are within the different contracts that you belong to. And so this is just information about the oral interpretation and sign language requirement, of which one is a notification of the availability of oral interpretation services that should be posted or distributed to your patients. So your patients are supposed to know that you have the availability of this. Now, the nice thing about Humana and many of these insurance carriers is that they have a web-based program for providers to link into to provide the translation services at no cost to the member. So finally, kind of in conclusion of all of this, I wanted to give you a few resources that you can go to for more information on MACRA and the Quality Payment Program. Probably the most vigorous one and the most helpful for me has been the first one, which is the qpp.cms.gov/education. There are many, many links that you can that it will take you to for information on the QPP, so that you will feel completely comfortable with this program as you launch into 2017. There is a full white paper on the QPP available, and there is a service center that is available to help you anytime you have questions. And then they're available at CMS Monday through Friday, 8 a.m. to 8 p.m. Eastern Time. So what do we do next? We know that this is a program that is going to be implemented starting January 1st of 2017. We know that we need to get on board by no later than October 2nd of 2017. So if you would like more information on how to implement MACRA or MIPS in your practice or any other services we provide, contact me. And my number is posted here on the presentation slide. I also have a toll-free number. You can email me, or you can reach me through the website at www.goldstarchirosolutions.com. I want to thank you all for listening to me today and for taking the time to learn about this very, very important process that will be affecting reimbursements to your practice next year and in many, many years to come. God bless and have a happy holiday.